Well, hello and good evening. Welcome to the Wolper Wellbeing webinar, hosted by Wolper Jewish Hospital, Friends of Wolper, and our special partner for this webinar, Kidney Health Australia. Our topic tonight is chronic kidney disease, how to keep your kidneys working better for longer. And my name's Julie McCrossin, and it's my pleasure to be your host. We'd like to begin by acknowledging that we're broadcasting to you from the land of the Gadigal people in the Sydney region, and to pay our respects to elders past, present and emerging. Just while some more people join us, I'll just give you some quick housekeeping. Your questions are welcome throughout our webinar this evening. In fact, you can start putting them now if you go to the Q&A on your link at the bottom. We also did receive over 50 or 60 questions from people before this evening. So thank you for that. And those questions are with us. Now, remember, tonight, we cannot see or hear you. Your only way of giving us additional questions is through entering them in the Q&A via Zoom. Our question moderator is General Practitioner Dr. Lena Safro, and she will be coming regularly onto the screen and to bring us some of your questions. And I did want to let you know that we will answer as many questions as possible, but obviously we're offering general information and advice. We can't go into the detail of individual person or patient questions. And remember that this webinar is being recorded, and it will be available shortly on the Wolper Jewish Hospital website, where there are in fact many recordings of webinars. Well, just before we begin, it gives me pleasure to welcome Dr. Lena Safro to make some opening remarks. Welcome to you, Lena. And you need to turn on your microphone, please.
Thank you, Julie. Tonight, we remember and honor the incredible bravery and sacrifice of our Israeli soldiers and police officers and all of the innocent victims of terror. Our hearts ache for families who have experienced loss. And so we pray for the safe and speedy return of the hostages, for the end of all loss of innocent life, and we hope for peace.
Thank you very much, Lena. Thank you. And for those of you who've just joined us, I can see a few more have come. A special welcome to you. If this is your first time at a Wolper webinar, Wolper Jewish Hospital is a specialist medical rehabilitation and palliative care hospital in the eastern suburbs of Sydney. And Wolper welcomes all people of every religious and cultural background, while offering care within a framework of Jewish culture, values, religious and dietary requirements. And it gives me enormous pleasure now, as we're talking about kidney health and keeping our kidneys functioning well for as long as possible, it's a great pleasure to welcome our partner organisation, Kidney Health Australia, and representing them is Stephen Cornish, National Community Engagement Manager. Welcome to you, Stephen.
Thank you, Julie, and thank you to Wolper Wellbeing Program and everyone for having us along and having us as a partner today.
Would you like to tell us about your organisation?
Yes, certainly. Thanks, Julie. Kidney Health Australia have been for over 50 years now serving the kidney community, working with them and the clinicians that are so vital in the support of their health journey. So we're obviously hope to be a trusted source of information for you all, which we offer many programs and services and information that's available for you to access. Best way of doing that is to check the website, kidney.org.au. You'll find all of our programs and services, a whole range of different information, resources across a wide range of topics in that website, which is pretty reasonably easy to navigate. We also have a helpline service which you can to call upon. Those numbers will be on that website as well, and that operates 9 to 5 Eastern Standard Time. The other services that we do have are peer support services. So we offer a kidney buddy program, which offers up that one-on-one peer support if required. Again, you can access those through the website. Other peer support options, a kids and youth program operating for our kidney families and young people especially. Other things like our big red kidney bus, which operates in Victoria, New South Wales and Queensland, offering up holiday dialysis services. So again, you can check those out if you're wanting to holiday and have dialysis at some of those holiday locations. Other services like Transplant House, which operates in 3 states, and there's just a whole range of different information and educational programs that can be accessed through the website. And we've got a fairly important one which will hopefully be launched in July, called Kidney Health for Life. So we're hoping that that's something that you can plug into and get further information around that. Obviously, we have lots of information around diet and nutrition, which we've been able to work alongside people that you hear from tonight. Kelly Lambert has been a great support. And of course, we have this all backed and supported by our clinical advisory committee, our primary education committee, which has all of the health professionals underpinning the information that we have. So as I said before, if you could subscribe, you'll get regular updates of our information, but very easy. Just check out the website. And again, we're very happy and pleased to be part of this education and learning session tonight. Thanks, Julie.
Thank you so much, Stephen. This is deaf sign clapping, so I'm enthusiastically clapping you. And I've had a really good look at your website, and it really is brilliant. And I know that we've got some slides from you that will be distributed to our viewers, and also a link to your website. So thanks heaps for being our partner tonight. Thank you.
Thank you.
Great. Well, ladies and gentlemen, just before we bring on our panel, whom we've got waiting in the wings, we're going to do a quick live audience poll. And this is to, excuse me, to introduce you to some of the key questions, but also to allow our panel members to learn a little bit about you. So I will read each question, you answer it on your screen, and then we immediately display the answer. So the first question will pop up on the screen now from our media man. Gender. Your gender is male, female, other, or prefer not to say. If you could answer the question, please. And we have 28% male, 71% female, and 1 person prefers not to say. Thank you. And we'll now go to age, please. Is your age 39 years old or younger, between 40 and 60, 61 to 74, or 75 or older? If you could click the one for you, please. So 9%, 39 or younger, 18%, 40 to 60, 28%, 61 to 74, and 46%, 75 or older. So 22% have a family history of kidney disease, 61% are currently managing diabetes or high blood pressure, 1% smoke. That's deaf sign clapping. Kelly, can you help me? Everyone start deaf sign clapping. 25% have urinary tract issues and inflammation in different parts of the kidney, and 31% are overweight or obese. Thank you. Cardiovascular disease, please. Are you aware of the link between kidney disease and cardiovascular disease? Yes or no? Yes, 39, and no, 61%. Terribly interesting, I think, that result, given what we know about you already. We'll go to treatment next, please. Are you aware of any of the newer treatments that have become available since 2023 for chronic kidney disease? Yes or no? Yes, 13%, no, 87%. So thank you. We'll perhaps talk a little bit about, in broad terms, about new medications. Diet, please. If you have chronic kidney disease, have you made changes to your diet? And you can give more than one answer. Limiting your sodium or salt intake, changing the amount of vegetables eaten, changing the amount of meat, chicken, or fish eaten, something else. Thanks, Nat. We might see where we're up to. 70% are limiting salt, 34% have changed the amount of vegetables, 42% have changed the amount of protein, meat, chicken or fish, and 35% are doing something else. Unfortunately, we don't know what, but good. Physical activity, please. If you have chronic kidney disease, have you made any changes to your physical activity? And just choose one, please. Yes, I've increased my daily physical activity. Or yes, I have decreased my daily physical activity. Or no, I haven't changed my daily physical activity. %48 have increased their activity, 5 have decreased, and 47 haven't changed. 47%, so roughly half. We have just one more question, ladies and gentlemen. It's about resistance training. Are you engaged in resistance training? Yes or no? And we'll get a definition later from our exercise physiologist. Yes, 40%, no, 60%. Well, ladies and gentlemen, thank you so much for taking the time to do that. It gives me great pleasure now to welcome onto the screen our panel, if we could have them all on the screen, to discuss chronic kidney disease, how to keep your kidneys working better for longer. And perhaps you could all wave as I introduce you. I'd like to introduce Associate Professor Ivor Katz, who is our kidney specialist, a nephrologist at St George Hospital. I'll tell you more when I bring him on. Welcome also to Associate Professor Kelly Lambert, who's a specialist kidney dietitian with over 25 years' experience. And also welcome to Professor Itamar Levinger, who's a professor of clinical exercise physiology at Victoria University from a place called Melbourne. I've heard of it somewhere along the line. If I could come to you, Associate Professor Ivor Katz first, if you could pop your mic on. You're a nephrologist, as I said, a kidney doctor at St George Hospital in the renal department and a conjoint professor at the University of New South Wales. We've got a pretty informed audience, but we will have a broader audience who aren't with us this evening. Just in a nutshell, what is a definition of chronic kidney disease and the sort of key symptoms? Welcome.
So welcome and thanks for having me on the panel. It really is a pleasure to be here. So I think the definition of kidney disease is that we have these two key markers that we, in fact, I work on primary care education committee for Kidney Health Australia. And the key thing that we ask primary care clinicians to look at is what is their kidney function? And we measure that by looking at a blood test on it's called the UEC, and they calculate something called estimated glomerular filtration rate. And that roughly tells us how the kidney is functioning. And most blood tests will have this EGFR calculation from your gender, your blood tests and certain other things. And then the second thing that we would generally do, and GPs are often doing this in the community, is checking to see if you are leaking any protein in your kidney. So those are the two definitions that we look at. And if you've got any one of those that are abnormal, below 60% functioning, or EGFR below 60, or if you have protein leaking more than a certain amount, that would amount to kidney disease. The other way that you can have kidney disease is you can have completely normal kidney function, and incidentally, they do an ultrasound or some test to look at it, and they find that you've got a disease in the kidney. That's a structural disease. The most common one being adult polycystic kidney disease, which is an inherited X-linked disorder that we will see. So those are probably the key ways, and we usually repeat those tests at least on 3 occasions over a 3-month period. And if it's persistent, then we will call that chronic kidney disease. So that's the sort of clinical definition.
And Dr. Katz, if I could say, what would we need to? Are there any symptoms that we would have which might where we might take that to our GP and they would decide to do that sequence of blood tests?
So I didn't answer that question, but the truth is that there may be none. And I think that is the key thing and message to take home, is that if you have the risk factors for kidney disease, and the ones that are outlined that are key are diabetes and hypertension, of course, if you have that, you should be doing the kidney health check regularly. They also, in that kidney health check, is looking at your blood pressure to see if you've got blood pressure. Of course, if you are a current smoker, if you have the risk factors for cardiovascular disease and kidney disease, which include obesity, a family history, or if you're part of the First Nations people, Indigenous Australians, they are at high risk, mainly for their disadvantage. And then if you are over 60, that on its own is not a risk factor, but those people, our kidney function does decline with age by about 1% from the age of 45. So you may not have kidney disease, but you are at risk of developing it because you could get acute kidney injury, and that in itself is a risk. So you could get a bad infection or something could happen. So in fact, we don't advise to wait for symptoms, because if you're getting symptoms, that's probably too late. We advise that if you've got risk factors or any one of the sort of 7 risks, you should really be going to see your primary care clinician, your GP, and have been checked.
Look, thank you. I'm 70, I've got diabetes and I'm overweight. I've got no idea if I've ever had one of those tests. So maybe one takeaway from this is for those of us who don't know, that we should talk to our GP about it if we have one of the risk factors that you've identified. Can I say, we spoke earlier before tonight and you said a key message is that a good quality of life is possible if you have chronic kidney disease, but it is lifelong and it requires regular checking from your involved health professionals. Could you speak to that? What is the sort of regular checking other than that test that someone who's crossed the threshold into chronic kidney disease should be doing?
Well, I think that you've got such a good group of experts on the panel tells you just exactly how complicated it is, and that really it involves primary care, your GP, specialists in exercise and diet and lifestyle. So all of those things are key. You are correct. Unfortunately, only 10% of people in Australia really are aware that they've got kidney disease. So, and so that is probably one of the big messages that we try and get out there with Kidney Health Australia, is to get checked. So it is a complicated disease. If you've got the risk factors, you should be going regularly to see your GP. If you've got diabetes or hypertension, you should be seeing your GP every year. And you should be having that kidney health check, which is looking at your blood pressure, looking at that EGFR, which is the estimated glomerular filtration rate, which is the little filters. And roughly that is equal to %. So if your GFR is 60 mils per minute, we can say your kidneys are about 60%, and you should be checking your urine to see if you've got leaking. So really, once you've got that and you detect it as having these high risks and you fall into those groups, you should go to your GP, and your GP should help direct you to specialists who can help you. Of course, you won't always be referred to a kidney specialist first up. we generally will be dealing with people with more advanced kidney disease or people that are more complicated and difficult to treat. And we generally provide GPs with guidance on who those people are who should be referred up. So in fact, most of the care can be done through your GP, and that's where you should be starting.
Later on, we'll look at the issue of dialysis and also kidney transplants. But just before I go to our other panel members and then questions, there are complications or adverse events to try to avoid through the good management you've been describing. What are some of the, I don't know if side effects is the right word, or just complications of chronic kidney disease that you're seeking to avoid through good management?
So I think I snuck in that question of, are you aware that kidney and cardiovascular disease are connected? And it was really quite a eye-opener that 61% people had no idea. So the truth is that only 4 out of 20 people, or even about 3% of people, will actually get kidney failure. By kidney failure, I mean they will land up on dialysis. So the vast majority of people will actually have cardiovascular events. So
and what does that mean, cardiovascular event?
So I'm going to explain. Those cardiovascular events are stroke or heart disease, or some people will have heart failure. And those are the serious events that we want to avoid. Or damage to your coronary arteries will develop with these risk factors. And in fact, you've got about a 3 times higher risk of getting cardiovascular disease when you've got kidney disease. So the things that we really are looking for is to try and prevent these cardiovascular outcomes, these stroke, heart failure, heart attacks, blocking of your coronary arteries, or developing these unusual arrhythmias. Those are the things that are much more likely to kill you or cause you severe harm than actually being on dialysis. So it is positive. You can treat these things. We've got great drugs to treat them. We've got good programs and advice around diet and lifestyle. So you can make a big difference, and those can make a big difference to your quality of life. Of course.
You go.
No, you were asking me, I think, can it change your quality of life? Of course, some people have advanced kidney disease, and if you unfortunately cross over into that group where you require dialysis, then it is a big change to your life. So that is pretty hard. And I always really feel for my patients and people I know who cross over there. So it is a very big change to your life. I often say you're almost like joining a religion, because it requires you to become this sort of serious convert and watch what you eat and how you eat. So have a really very rigorous lifestyle. But there is a lot of support for people in Australia. Australia's got excellent outcomes, fantastic systems, really good databases that track us and make sure that we're doing the right thing. And you can be sure that when you reach those stages, Australia sort of is right there, right in the front, achieving great outcomes. So we can help you.
Look, thank you, Dr. Katz, and I will come back on medications and other issues, but I'd like to welcome now, if I may, Associate Professor Kelly Lambert to join us. And Kelly Lambert, as I mentioned earlier, has been a specialist kidney dietitian for over 25 years. She's a fellow of Dietitians Australia and Associate Professor at the University of Wollongong, and her research areas can be summed up as really helping people with kidney disease to live a better life. So I'm going to welcome you with a bit of deaf sign clapping, just because it's such a full thing. Just before I ask you questions about diet, you saw some of the information coming from our audience. Was there anything that surprised you or interested you that you'd like to comment on, Kelly?
Oh, I'd love to know about that other question. What else are people doing in terms of changing their diet? But there's some positive signs that people are making the right choices in the right direction. So I'm happy about that.
Excellent. So, when I asked you when we spoke before, what are the key messages, you became very specific about the right diet. So including make sure you have 2 serves of fruit and 5 vegetables a day and protein about the size of the palm of your hand. Now, that's classic diet advice, isn't it? But why is that particularly important for people with chronic kidney disease?
A couple of reasons. Let me go back a step first, though. So the diet for people with chronic kidney disease is actually very complicated, and it can be simplified, and there are some common messages. But what I would like to communicate first is that the diet prescription changes as you progress through the stages of kidney disease, and there's 5 stages. So the diet in the early stages is very different from the diet at the end, and that's because we're managing complications from kidney disease and the treatment that we give people. The common kind of theme across all of those stages is that fruits and vegetables in particular actually have a couple of different really positive effects. So the first one is they actually improve people's satiety. So you don't eat as much food when you get enough fruits and vegetables. And it also helps with fiber, which means you can poo. And that's really important because what happens as your kidney function deteriorates is that you get an accumulation of what we call uremic toxins. And by pooing regularly, you actually get rid of some of those. So it actually makes you feel less sick. And then the other amazing thing about fruits and vegetables is that they are as effective as some medications at helping balance your acid-base balance in your blood. So 3 or 4 different amazing reasons why you need to get the right number of serves of fruits and vegetables.
And tell us about the protein. Are you saying there's an ideal amount depending on what stage you're at?
It is, that's right. It does change according to your stage and also whether you have diabetes and also whether you're doing dialysis. But a good general rule of thumb would be about the size of your palm, so that big, about as thick, not including your fingertips. That should be fine for most people in the community. If you're on dialysis, it's slightly different and you actually have to eat a little bit more protein, and that's because we have treatment which removes protein from the blood. Yeah.
I see. And if you're eating packaged food, which you may be discouraging because there's an if at the beginning of it, but if you are, it's terribly important to read the information panel. Can you explain why?
Yeah, there's a couple of reasons. One is that there's lots of added salt to foods that people don't necessarily realise is there. So, for example, cornflakes are particularly salty, but you don't necessarily feel or taste that when you're eating them. But the second thing that's really emerging as a major problem is that many food companies are producing foods that are packaged or marketed as reduced salt, but they actually have potassium chloride added to them. And people with moderate to advanced kidney disease, that's actually very dangerous. And we need to be reading food labels to make sure we're not eating those foods with those ingredients in them.
Could you say that ingredient again? Potassium?
Yes. Potassium chloride. So that's particularly a problem because it can accumulate in the blood in people with moderate to advanced kidney disease, and it can cause heart arrhythmia and can potentially kill somebody. So if you have moderate to advanced kidney disease, we're battling 2 things. One is we want you to eat less salt. So people want to choose packages that have less salt, but they may not realize that to achieve that, they're actually eating potassium chloride at the same time.
And can I ask you, are there other things we should look out for on the packet? And if so, are they on the Kidney Health Australia website? Or is that something you need to talk to a dietitian about if you do have chronic kidney disease?
Yes to both and all of those questions. There is a group of additives called phosphorus additives, which are added increasingly to packaged foods. But not everyone needs to follow a restriction of those particular additives. It's mostly people at the latter stages when you have kidney failure. But again, that's actually very challenging because they don't always have to declare these things on the food label. So you have to literally be reading the ingredients list to figure it out. But it's only applicable to a certain group of people. So that's where a dietitian will be able to give you individualized, yes, it's appropriate or it's not appropriate for yourself. Yeah.
I'm going to go to Itamar, Levinger, and then go to our questions. But can I just say, as someone who's 70 with all the appropriate body changes, I've recently bought at my chemist a giant microscope. Magnifying glass, and it's actually got a light in it. And when I'm looking and I'm revealing to you I've got probiotics here, and I don't know what you think about probiotics, but I can't look at the size of the print.
I can't read it either.
And I've got medications. Look, I won't get all my medications out, but here's one I have to get my magnifying glass out to read it. So what you're saying, apart from understanding it, for some of us, because it's an older audience, is just seeing it, isn't it?
It also brings it back to preparing your foods from scratch and fresh. You know, you can avoid that complication if you're having more foods prepared from scratch.
And is that what if you had chronic kidney disease, is that what you'd be doing, preparing food from scratch?
I think you're asking a biased person there. You know, I'm a dietitian, so I'm very focused on that kind of thing, but I would, because I know there's a benefit to it for sure. But I do absolutely appreciate, for many people, they don't want to spend, or they can't spend the time reading through every food label. So that's where we can give you some much more specific advice to help people look at food categories. Yeah.
Well, we'll come back and remind me to ask you about the Jewish food, because I think you've done some research for our Jewish viewers. It's my pleasure to welcome Professor Itamar Levinger to the screen, Professor of Clinical Exercise Physiology at Victoria University, an accredited exercise physiologist. And your research and clinical focus has been particularly on exercise rehabilitation for people with cardiovascular and metabolic diseases and more. So a big welcome to you. Comments on anything you've heard so far that you'd like to agree with and emphasize before I come to your particular messages?
Yeah, no, I agree with everything. That's what people done. I saw that most of the people who attended, over 70%, I think, are females, and around 50% only involved in some level of physical activity, which is more or less the average that we have in the Australian population in people over the age of 60 or 65, which is a bit of a concern, I must admit, because we use exercise as medicine, and it's probably, you can prescribe it for free for everyone, so you don't need to pay for it. You can do it in your own time. And it's incredibly effective, particularly in managing and treating, and also the prevention of what was said here before, which are the risk factors, the major risk factors for diabetes, including overweight, obesity, improve sugar control in people with diabetes, reduce hypertension, reduce high blood pressure. And particularly in this population, it's also, that's why I ask about the resistant training, to improve the loss of muscle, to regain and minimize loss of muscle mass and bone mass, which is so prevalent in women, and osteoporosis. And we don't have medications for the loss of muscle mass and strength. There is only one very good medication, which is resistance exercise.
Explain what that is, resistance exercise, please.
So resistance exercises, we are classifying broadly two classes of exercises or physical activity. One, it's resistance exercise, which is weight bearing. So everything that is done against resistance. So if I need to push or lift something, whether it's my body weight or whether it's external weights, or even when sometimes I carry groceries, this can be part of our weight training, because we are carrying things, we are beyond our body weight. And that is very good. It's incredibly effective when we are targeting muscle mass and strength. It also can then assist us in fall prevention, which is also one of the concerns that we have. And also to build up bone, which is very difficult as we're getting older and older. And particularly when you start to superimpose that with conditions that can create bone loss. So this is the weight training. And the other one, it's aerobic exercise, and probably most people know about walking, swimming, something that is more repetitive. However, and this probably I will touch a bit later, we also consider dancing, for instance, as an aerobic activity, because we are trying that people will enjoy it. It doesn't matter how good my exercise prescription, even if it's optimal, if people will not want to be involved in that, or if they will be bored by that, they will not do it. So we're trying to find this balance between what people love to do and also the benefits that we would like them to have.
Now, my understanding is that you believe exercise for people with kidney disease, particularly chronic kidney disease, is absolutely critical, and that choosing something you enjoy even if you do it to a smaller degree than another, I don't know, more dynamic version of exercise, so long as you've got something you enjoy, you're more likely to do it consistently, and that will deliver benefit. Is that the critical message?
Absolutely. So first of all, yes, for your first point, exercise. And what we are trying to do now is to move away from the word exercise, because a lot of people have negative connotation with this word. They were in school, they were punished, go out and do some exercise and things like that. So we are trying to move into physical activity and improve physical activity. And that can be structured and non-structured. And yes, it is better that someone will enjoy the physical activity that they're doing, and they will do a little bit every day, let's say 15 minutes, 30 minutes or so, things that they love to do. Then they will do something that's on paper will be very beneficial for them, maybe even more than what they like to do. But after a few weeks, they will stop. Small increments over time, and when I said over time, I don't mean days and weeks, but rather months and years, will have an accumulate benefits. And that is the key factors. And also you start to change your lifestyle like that, then you can incorporate into the dietary modification, if you like, to improve it overall. So it's not just the physical activity by itself. I think it's a multidisciplinary approach that everyone can contribute small portions, but the overall benefits to the patient is quite large.
Look, thank you so much. I'm going to invite now Dr. Lina Safro to come on, and let's hear from our audience questions. And if I could invite our whole panel to come on the screen so we can move swiftly between you. But Lina, welcome to the screen, if I could have Lina on as well. And Lina, if you could bring us a first question from the audience, welcome.
Thank you. So there are questions to all of the panelists. So I might start with Professor Katz. There's some other risk factors, apart from the ones already mentioned, for reduced kidney function. Things like diuretics, things like dyes used in imaging, such as CT scans, or having had one kidney removed. Are any of these a predictor of reduced kidney function?
So there are always what we call them nephrotoxins. So there are potential drugs that are dangerous for your kidney. Now, it's usually at different levels, and generally, if you're on any medication, you should be cautious if you've got kidney disease to adjust them. And when you see people, tell them that you're on these medications. So sometimes even the medications that we use regularly, which are standard medications to protect your kidneys, can be dangerous. And that's why we even have this concept called the sick day plan. That's quite a new concept that we're trying to push across. It's been there for a long time, but we're calling it a sick day plan. And basically what it says is if you're unwell, if you're on any of these drugs, which the GP points out are dangerous, we say stop them until you feel a little bit better, and you can restart them. So these are the traditional drugs. People may know their names, like ACE inhibitors and angiotensin receptor blockers, which are the core. And then there's the new drugs that have come onto the market. And one of those is diuretics. So diuretics aren't dangerous for the kidney. Sometimes you need them because you've got kidney failure, but these drugs can be dangerous if you're dehydrated or if you're unwell. So per se, they're not dangerous, but in the situation that you're in or in the context that you're in, they can be dangerous. Similarly, contrast is not necessarily dangerous for your kidneys if your kidneys are working at a certain level, say more than 30% generally. But if they're working under that, you may need somebody to watch the kidney function, or you may need to be prehydrated with fluid. In some instances, people will get that via an intravenous drip to get fluids before. So these things are just important to be aware of, but they're not necessarily always toxic to the kidney. So it depends on the circumstances. If you've got kidney disease and you're doing those sort of things, you need to be speaking to your doctor, your GP, to check, is it safe? And when you're going for procedures, you need to tell people what medications you're on. Some need to be withheld and you just need to make sure you've been advised accordingly.
And Dr. Katz, could you just explain what a diuretic is, please?
So a diuretic, I mean, one of the key jobs of the kidney is to control, to remove toxins and also to control fluid balance. I mean, the easy way to know it, when it's pretty cold, all of a sudden you're going to the toilet a lot more, and that's basically your body recognizing you're sweating less and it needs to get rid of fluid from your kidney, and your kidneys will adjust that. So drugs that we use when you start losing filters or some of the parts of the kidney are damaged and you're starting to accumulate fluid because you have that damage, we may use these tablets called diuretics to stimulate the kidney to pass more urine. We may use them if you've got heart disease as well. So if your heart pump is not working that well, it will impact on the kidney. So in those situations, the kidney and the heart are sort of sending each other the wrong messages and holding on to fluid, maybe to increase the blood pressure. And in those situations, we may use drugs like diuretics. We've got different types for different situations, but they're all potentially used in different situations. They're good, but they can be bad. So there's always the good, bad, and ugly with medications, unfortunately.
Thank you. Lena, another question. Thank you.
Just there are quite a few questions here in the chat about nephrotoxins, Professor Katz. Specifically, Nexium and creatine for those people who want to use it as part of their gym routine. Can you please make a quick comment on those?
And explain what it means, if you would. You've turned off your mic, Dr. Katz.
So look, I'm going to leave the creatine to Prof. Levinger. He can answer to that because I'm sure he knows it. But in general, nephrotoxins, would be any drug that you use. Creatinine, we don't advise to use those sort of things. In certain levels, they can be dangerous to the kidney. But in terms of just nephrotoxins, sorry, just repeat that first part of the question that you were asking.
Someone wanted to know if Nexium is...
Okay, so Nexium, right, Nexium, which is known as a meprazole or a proton pump inhibitor. These were drugs, just to tell people, that were brought onto the market to very good drugs and very powerful to prevent ulcers. Now, there is quite a lot of evidence suggesting that these drugs can be bad for the kidney. And I'll make it sort of clear, they're bad for the kidney if you use them inappropriately and if you use them for too long. So if you have a disease that you need it, and often you need to use these drugs for periods of time, you should be checking that whether you can stop them or not. So if you've got a clear indication, some people have very bad reflux disease and they need these medications, of course you don't stop them. But if you should be looking to, there is quite a lot of evidence to say using these drugs inappropriately for long term is dangerous for the kidney. They're one of these drugs that we sort of just put ourselves on and forget about. I don't think any drug you should be on and forgotten about. I think the principle is you should be seeing your GP. If you're on medication, you should be seeing your GP and checking that you should be on all the time. I will say Nexium, which is a PPI or a proton pump inhibitor, is one of those drug classes that are now being implicated to potentially cause kidney disease. And the evidence is coming out more and more. So I would just say the message is, if you're on one of those, check with your doctor whether you really should be on and you've got a good indication, and check whether you can stop, because if you can stop, you should.
And Dr. Katz, just explain what sort of conditions you might be on one of those, that drug for.
So you would be for chronic severe reflux disease. There's certain diseases that can damage the esophagus. If you've had ulcers and you've got serious diseases, there's diseases that are associated with ulcers like Zollinger-Ellinger syndrome. I don't want to make you go look those syndromes up, but there are certain diseases that will cause ulcers, and you can't. Most of the time, it's from a bug called Helicobacter pylori, which you can get rid of. And that was an Australian who found it out. And you can eradicate them. And if you eradicate them, you probably could stop the drug. So, if you've got it and using it for ulcers, it's not always that you need it forever. You may, once you've eradicated the H. pylori bug in your gut, that you can now stop them. So you should check with your GP or your gastroenterologist specialist who is managing it.
The one message I'm getting from you, Dr. Katz, is you need regular contact with your primary treating doctor, and you need to be talking a lot. You need communication to manage this effectively because it's complex.
Look, people often tease me. I know when I try to get extra insurance, the insurance broker told me I visited my GP way too much, and I had no chance of getting an increase. But I think that's the wrong message. The message is that you've got to see your GP, and you've got to see somebody independent who can look after you. When you go above the age of 30, and certainly as you get older, you need to be seeing your GP regularly. That's why they're there, to pick up these diseases early, act early, and kidney disease is a disease that if you pick it up early, you can prevent it. If it's established, it's really much more complicated to manage.
Thank you. Just before I come to Lena for another question, does Kelly Lambert or Itamar Levinger, do you want to comment on anything that's been... Kelly, did you want to come in?
Maybe on the creatine.
I was going to say it's actually creatine that I think people are using for muscle building. And to me, it's actually very overrated. The best way to build muscle is the right type of exercise, which Itamar could talk about, and making sure you get enough calories and protein. Creatine is like the icing on the cake, and it's unnecessary. But I have seen people overload on it, and it can cause some problems. So I would just get rid of it, to be honest.
And Kelly,
and maybe
is it
see
something you
an
buy
EP.
over the counter, or is it by prescription?
Yeah. No, you can buy it over the counter.
I see. Itamar, your comments on anything, please.
Yeah, no, I agree. It's funny because my son just started to use it, but he's a teenager and I couldn't stop him. But so creatine can help in build up muscle. The problem for people with chronic kidney disease is the filtration, and they already have quite a high level. And then if you're topping up with more, it can have even more damage to the kidneys. We are not recommending that. We don't see exactly what Kelly said, any additional benefits for people with chronic kidney disease to take it. I would also suggest to just avoid it. You can get all the benefits from your training and your gym workout without that. You don't need anything else.
That's Dev sign clapping. That's good to know. Dr. Safra, could we have another audience question, please?
Sure. We've got quite a few questions here about diet, and specifically about the bananas, dairy,
yes,
and keto diet, and
yes,
how that intersects with chronic kidney disease.
Okay, I'll start with the easy ones. So in years gone by, we had very prescriptive lists which had foods to avoid and foods to include. And we've actually moved away from that now, because we know that really there's no one particular fruit or vegetable that's a problem. It's about quantity. So if you stick with the correct quantities, including a banana, so what you fit in the palm of your hand, so half a banana would be one serve, then you can have 2 serves a day, a banana every single day, and no other fruit, and you'd still be fine, and it wouldn't put your potassium up. So people don't necessarily need to avoid those foods, especially if they're Googling on the internet and they'll see those lists of foods to avoid. They're actually outdated, and if they're from overseas, also potentially inaccurate and incorrect. So I think that's probably the gist of that question. Was the other one dairy, did you say?
Dairy.
Yeah, so that is an important one. So when you get to about 45, 30% kidney function around that region, that's when we really start to have to restrict the amount of dairy products we eat. And that's because it contains both protein and phosphorus and potassium, and those are nutrients that we need to modify. But be guided by your dietitian and your nephrologist about that stage of kidney disease, because they should also be on some specific medications to help manage the phosphorus in your blood. It's a kind of a I can't think of the word. You need a three-pronged approach to manage phosphorus in the blood, and diet's part of it, medication is part of it, and there are some other things that you may need to do. So we want people to be cautious about dairy products in the moderate to advanced stages, but we know that if you've got early kidney disease, dairy products are actually a good thing, and we want them to have 3 to 4 serves every day.
Just before you come keto diet,
Yep.
could I just ask you, is this information you're giving us on the Kidney Health Australia website?
So I can answer to that. It
Yes,
is
thank
there. It is there. I sit on that primary care education advisory committee. All the data, and I think Kelly's made a really important point, that use reliable websites to go to, ones that are local, Kidney Health Australia, Wollongong University Diet Department, go to things that when you start looking online, you'll find a whole lot of people saying a lot of nonsense. And that is part of the problem with AI. When you get the information, you're not sure it's accurate. So you need to be sure when you're going on that you use a reliable website. And most of these things, there's lots of resources on Kidney Health Australia. And there's booklets that you can get when you're living with kidney disease, which will cover a lot of these things. And I'm sure Kelly's been involved in writing some of those.
Yeah.
Can I just jump in? Sorry, Julie. It's because you have the medication side and you have the diet side, and both of them will try that you will lose weight and also improve and reduce proteins, which is okay. But we also need to remember that when you start losing weight and you're reducing the proteins, you're not just losing fat, but you also lose muscle and bone. So we really, really need to make sure that you're not just modifying your diet without a corresponding change in your physical activity. And that's why I'm going back to the weight-bearing exercises, particularly when you start reducing the proteins, which are really important for muscle mass strength and your daily function at the end. You really need to ramp up a bit of those weight-resistant training to protect your muscle. Otherwise, you will go to a vicious circle that when you're going into those treatments, your physical functioning will drop. You increase the risk of falls and fractures, which then cause other issues. So we really need to try to protect the muscle and to incorporate that with appropriate physical activity.
Thank you very much. Now, I just want to check, Dr. Safra, did one of our questioners want to know about the keto diet? Did you say that as well?
Yes.
Yes. Could you comment what it is, Kelly, and then whether that's appropriate?
So it's very topical for many people with kidney disease because they're commenting on using it online. So the keto diet is an umbrella term, a general term for a specific dietary prescription that is low in carbohydrate, very high in fat, and relatively high in protein. Traditionally, it's used for people with epilepsy, and it can be used for weight loss, but there's also some animal studies that have used it in people with polycystic kidney disease to help slow down the growth of the cysts, but that has not been demonstrated in humans to date. So I'm going to address that question by saying, in general, if you are trying to lose weight, a keto diet is one option, but in my opinion, it's not the best option for 2 reasons. One is that it's really challenging to stick to. And 2 is that there's actually medications on the market now that would be far more effective and helpful for your kidneys to help you lose weight and protect your kidneys at the same time. And I would actually say that that's a better choice. If it's about your polycystic kidney disease and you're wanting to do as much as possible to stop the path to dialysis, the evidence is not yet there that that's actually an effective way to do it. And I wish it was, and I would be talking and supporting it if it was, but it's too early to tell. There's been no human studies that have actually demonstrated that it's effective. That would be my short answer.
Look, thank you. And I'm going to take one more question from Dr. Safra, and then I've got a couple more things I want to ask, and then we'll close with more questions. But Dr. Safra, another question, please.
So we've got a couple of interesting exercise questions here. Somebody wants to know if pole dancing qualifies as resistance exercise, and is it useful?
Absolutely. Yes, it's required a lot of strength. It required a lot of core stability, and it can be very, very helpful. And if it's also enjoyable and it means that people will stick to it for months in years, I think that can be a very good exercise.
Itamar, is there any chance you've got a pole nearby and you could just demonstrate what pole dancing is?
It's outside my qualification. I'll have to Google it later.
It's one of those things that is both exercise and something of a more sexual nature, but so pole dancing is always an interesting topic.
Well, there are actually classes now for pole dancing as a weight training exercises in groups, and usually it's closed only to women, so there is no embarrassment and thing like that. But it's exactly like what's in the a few years ago we have the aerobic exercises and aerobic dancing and thing like that. Yep, I think that is good.
No, so I didn't mean to be silly there. It's incredibly physical and has an amazing core, and they must have extraordinary muscle strength, that's for sure. Are there other exercise-related questions, please, Dr. Safra?
Sure, Julie. So there is something called CASA that I'm not familiar with, but somebody wants to know if it's useful in preserving muscle.
Could I just ask, Nat, has Professor Levinger been posted on the screen, so he's highlighted as a speaker? I just wonder if you could check that. But sorry, if you could explain what that is in your comment, please.
Well, I'm just wondering whether it's like one of those new machines on the market, because there are a fair bit of new machines that every time comes with different names, and it's pretty hard to follow up of the new case. I think it's like new diets that every time someone comes with different names. So I'm not familiar with that specifically, so I can't comment on that. But there are very limited amount of new exercise machines that people can invent. I think that the key aspect, though, I'm really not sure what this machine does or whatever. You don't need, and this is one thing that it is important, I think, for the audience, that's to do your physical activity for health, for your benefits. You really don't need any sophisticated machines. You can actually do it with your own body weight. You can do it at home. You can go outside for a walk. You can do it in a group. And this should not stop you from doing your physical activity. There is so many options of, to do the physical activity that you need, including building muscles and bones without any equipment, that it's freely available. So I would not jump just to buy every time the last thing that you see on the market. This is just general advice.
Well, thank you. Associate Professor Kelly Lambert, can I just ask you about consumption of water? Are there any messages about how much water one drinks or should not drink, please?
Yes, water is the best drink to drink, but the problem is as your kidney function declines, you cannot drink water as freely as you might have done in the earlier stages. So that old adage of, drink lots of water to flush out your kidneys doesn't actually apply to people with moderate to advanced kidney disease. And in those cases, you may actually be on what we call a fluid allowance. So you might be restricted to 1,200 mils or a litre a day. But water is definitely the best choice of fluid. It's just that you need to check with your doctor, specifically a nephrologist, if you've got advanced kidney disease, about how much is appropriate.
Look, thank you. And I'll come back to Dr. Katz. Oh, good. You go first.
Well, I just wanted to interrupt because I think Kelly has alluded a couple of times to the stages of kidney disease. And I think it's quite important for people to understand what that means. So about 20 years ago, 25 years ago now, we sort of divided the stages up into 5 different stages. Some are subdivided, but they're based on that number I spoke to you about, the GFR. And we often say to patients, know your number, know what your GFR is, know your number so that you can understand where you are. And that also helps you to understand that your kidney has about 7 jobs, and those jobs will be less efficient. It can't do them as well as you enter the later stages. And it depends on the percent function. So when Kelly's referring to severe, moderate to severe, she's talking about when your kidney function is sort of around 45% and less. And obviously people who are going to start or need dialysis, their kidney function is under 10%. So there's a large range that things are happening, and not everybody reaches an exact point in those stages and then stops doing things. It takes your dietitian or your kidney specialist to look at those different things and say, okay, you in this stage, we have to look out for these sort of jobs that your kidney is going to stop doing, and check and support those jobs.
Dr. Katz, let's move to dialysis. If you could just remind us what proportion of people may need it, but also talk about the kidney supported care pathway, which I think you think is important for people to know as an alternative to dialysis for the right patients, please.
So about 25,000 people are on dialysis in Australia, and they say there's probably about the similar amount who are not on dialysis. So when you get to requiring dialysis, your kidney function is usually working below 10%. And we have 3 options to support your kidney if it's not working at all, or to a level that is dangerous, that will cause you to die prematurely. So if it's below that, we can do home dialysis therapies, which are always our choice. Peritoneal dialysis, which is putting a special plastic rubber pipe into your abdomen, into the cavity, and your lining of your cavity acts as like a filter, and the fluid goes in and it cleans out the toxins. So it does some of the jobs that the kidney would do. So that's called peritoneal dialysis. Then you would do something called hemodialysis, which you can also do at home. That's a machine that requires you to have a special access, we call it, where you can take the blood out of your body. It gets cleaned out through a filter and through various methods, osmosis and pressure, to remove the toxins. And of course, those are choices whether you go. You can also go on in-center hemodialysis, which is unfortunately where a lot of people are in Australia, and we try not to. So dialysis is the option, and of course transplant. So you can get a transplant either by waiting somebody you know, a related living donor, or you go onto a waiting list and you'll get an unrelated living donor. So those are the traditional options of dialysis. But as we get older, and that's when kidney disease occurs, when we get older, so we also get other diseases as well, heart disease, heart failure. When you've got a lot of these comorbidities, as we call them, the doctor's term, and you're getting older, or you become more frail, then dialysis may not be an option for everybody. And I suppose that's why Itamar was talking about being fit and being healthy, because if you're fit and healthy at every level, wherever you are, you will always do better if you are fit and you functionally are well. But some people are not, unfortunately, and then they may choose something called a non-dialysis pathway or a conservative pathway. There's various names, but currently it's called kidney supportive care. And it is a pathway. In Australia is one of the countries that have revolutionized it and sort of really taken it on. And essentially what you do is you choose a non-dialysis pathway where you're supported by dietitians, by your doctor, by somebody who watches your symptoms. There are specialized nurses who support you, social worker, and support your home. And they basically just manage your kidney failure until you pass away. And the whole process is supported all the way along, right till the very end. A lot of the people in that area are actually palliative care specialists who have specialized in these chronic diseases. Some of them are kidney specialists who have also become palliative care specialists. So there's different ways you can go into that conservative pathway. Your survival may be a little bit less, but your quality of life will be quite significantly improved. So instead of needing dialysis every day or 3 times a week, or whenever you're doing it every other day, you won't have to go to the hospital as regularly. You have a better quality of life, and a lot of these symptoms are supported. And that is probably one of the biggest growing areas of kidney disease management when it's advanced.
And is there any research yet on the proportion of people who choose that pathway?
So when you come through the hospital, there's a lot of research written on it, and it's quite a significant amount. It's probably in that age group now. Certainly if you're coming through our hospitals, it will be as high as 80% if you fit into the categories. People are well informed. and educated around it will often choose that pathway. So it's really for people who have a lot of associated diseases or are more frail. So it's not for everybody. If you're well, or you're younger, or you're fitter, that may not be something that's for you, but it's something that you can discuss with your kidney specialist if you are in that group.
And just tell us a little bit about the clinical nurse consultant kidney nurses, because they're crucial, aren't they, for people either on dialysis or being supported, sort of for both psychological support, but also care and information.
Look, I think any nurse consultants in Australia are very, very well knowledgeable, and they are people who will support you in specific areas. So we have quite a lot of kidney nurse consultants who specialize. I work with some who work in community with early disease detection and advice and education, or pre-dialysis education. There's nurse consultants who work in kidney supportive care. There are nurse consultants who are working with patients who need access placement. So they really are very specialized nurses within a specific area, who understand it and have worked prior to that. Generally, if they're in kidney disease, they will have worked with people on dialysis or somewhere along that line.
Just before I come back to Dr. Safra for a question, could I just ask our dietitian and our exercise expert, you know, are there comments to be made about diet and exercise for people in that more advanced stage where they may be on supported care or dialysis? Would you like to comment first, Itamar, Levinger?
Yes, so people on dialysis can do exercise. In fact, there are some studies that utilize exercise while they're on dialysis. Particularly, they can do exercises with their legs, for instance, or with the arm that is not connected. So, and we have, when we published the exercise guidelines, the Australian exercise guidelines for people with CKD, we also included guidelines for people with dialysis or on dialysis. We are actually updating that for 2026, but you can't do that. Of course, that the intensity needs to be adjusted, and it needs to be in consultation with both with a treating doctor and by accredited exercise physiologist who knows what they're doing. But it is possible, and it's very, very important. So you almost have 2 hours or so that's available for you. You're already there to do the exercise, but it needs to be done under a controlled environment.
I can imagine. I mean, it's not only that exercise is always a benefit, it's also psychologically. I've had a condition which involves sitting for a long time with something being dripped into me, and having something to do is helpful. But Kelly Lambert, the diet approach to someone with really advanced disease.
Yeah, in the supportive care space, it's all about quality of life. So we would be avoiding restrictive diets and just providing people with a dietary prescription that helps manage the symptoms that they may have. So if they're particularly nauseous, we would provide some advice about how you would manage that nausea. Or if they're having difficulty with their fluid, then we would provide advice about that. But it's very much about liberalising restrictions to maximise your quality of life. Yeah.
Thank you. Dr. Safra, any more audience questions, please?
Yes, we have got quite a few questions related to younger people with kidney disease and to children. And people are asking for comments about how the management of children with kidney disease differs from the management of adults.
Could I come to Dr. Katz first, please? If you could give us an overview of the experience for children and then your comments on treatment and care, please.
So look, I'm not a pediatric specialist, so I'm going to give you sort of very general guidance. But mostly when kids are getting kidney disease, it's not from diet and lifestyle. It's usually from inherited diseases or where they have got rare diseases that attack the filters in the kidney. So it's usually those two categories, or they have some anatomical abnormalities or differences that will put them at risk for kidney disease. There's a number of different things. So those children fall into a different category. The advantages of children is that if unfortunately they do deteriorate, I think the same principles will occur when you've got kidney disease, when the jobs of the kidney are not working, and that includes not removing fluid or you're getting blood pressure. They will need the same medications that adults will need to support them down the pathway. They will require the same dietary support and exercise support. And there's quite a lot of services that we offer for younger people who are got kidney disease, because very fortunately it's not as common as with adults, so they get well supported. But if you are young, then you will be involved with a kidney specialist and a pediatric kidney specialist much earlier on.
And I imagine Kidney Health Australia have peer support. I can just instinctively...
Lots of peer support. For those things, there's lots of groups, and you would find groups that are specifically supporting young people with kidney disease. So obviously, when you're young and you've got kidney disease, it's much more of a challenge. Your lifestyle's impacted, and it really makes it difficult for you to live a normal existence like young people. So we try and facilitate that as much as possible. We've got a couple of our nurse consultants who work in those, setting up those sort of groups. And there's lots of people putting funding into trying to create those groups. And they usually, in most of the major centres in Australia, they will have groups that people can connect. And you would probably find them through Kidney Health Australia. They've got very good support networks to help you find those groups.
Thank you. Kelly Lambert, your comments on diet in relation to young people.
Yeah, I would actually implore anyone who's got a child with kidney disease to connect with a dietitian, because we're not only manipulating many different nutrients behind the scenes, we're also trying to support the child's growth and also avoid malnutrition, so that if a kidney transplant is going to be an option, we need to get them in tip-top shape and keep them like that so that a transplant is successful. So a dietitian will become one of your best friends in that sense. But I also know from work that I've done with the pediatric population that it's a very lonely journey, and parents definitely need to connect to other parents, but also children need to see other children in that space for their own mental health. So it's really amazing the support Kidney Health Australia provides in that space. It's so warranted. Yeah.
Look, thank you. And if I could come to you, Itamar, in relation to exercise in children.
Yeah, so I'm not an expert specifically in children with physical activity, but I do agree with the sentiments that were raised here before. Physical activity, I mean, usually when you have such a young patients, it's usually there are other things that involve. So you're not just having isolated condition. It's actually something that it's a bit more complicated. But having physical activity and the interactions, the social interaction with others is incredibly important. You don't want kids and adults also to be isolated. And I think that's having the right social support, the right structure for physical activity can actually bring people together, and they can share the same, that they are not alone. And it will not only improve the physical function, but more importantly, and probably that will be my final remark when we discuss it, but also will improve the mental health and reduce depression, which is highly prevalent in this condition. So it's like an overall treatment, which is very important in young age.
So could we come now to that psychological question? I will get one more question in from you, Dr. Safro, but as you've raised it, Itamar, your key message about the psychological well-being of the person with the diagnosis, but also the family.
Yes, so, and that's one of the reasons, and I know that I'm a bit biased toward physical activity and exercise, so forgive me about that, but it's really one of those activities that you do one thing, but it can treat multiple conditions, including physiological conditions, and if you have diseases, cardiovascular disease, diabetes, improve muscle mass, it all can be done with one free treatment. But also importantly, the mental health. We know that people with chronic kidney disease, but also people with cardiovascular disease and diabetes, and all people who are obese, have higher rate of depression and anxiety and mental illness compared to other people or the general population. And we know that physical activity is one of those strongest stimuli to improve mental health. Even just the fact that you're going outside of your home or the hospital, you have some fresh air, you have some sun, some vitamin D inside you, you interact with other people, that can change the course of your life. It can improve your quality of life. It can reduce your, as I said, depression, and improve your mental health, and also almost lead to independent after that living with all these beneficial. So it's very, very important. And if you're doing that with a friend, you also have a social connection, that someone that can push you and support you when you feel down and you don't want to do the exercise. You actually can build up like a protection shield, that people that will help you when you're down. And we know that the clinical journey of patients is like a roller coaster. You have good days and you have bad days, and you really need those support when you're in your bad days, and of course that you can be there for your friend when they are in their down days.
And earlier on you were saying how important it is to enjoy your movement. In order to move. I have a diabetes diagnosis, and I'm with an exercise physiologist once a week in a group of just 6 of us, and the camaraderie and humour that arises when you put 6 Australians in a room. All we've got in common is a diagnosis. It's you sort of the other thing I would say is it's important to like the person who's leading your exercise. I think if you like that person, you're more likely to front for them because you don't want to let them down. If I could just offer those observations. Kelly Lambert, do you want to offer any comment around diet and psychological well-being?
Look, there is the potential to get really obsessed about following a diet when you've got kidney disease. There's so many nutrients, and people often go, well, I'll just eliminate a whole food group. It's safer if I don't eat a whole food group. And we don't want people to become like that. There's really very few items that I would say you can't eat. It's all about how frequently you eat them and what portion size. So the best advice is to come and see somebody who can help you understand how to live your life, enjoy food, and all the social occasions that go with it, and to manage your kidney disease and your diabetes and your high blood pressure. So I don't want people to feel like they need to become obsessed with learning lists, because we're moving away from that approach to managing diet.
And quality of life is eating meals together is so critical to mental health, isn't it? And particularly for young children. We've talked about young children as well. It seems if you eat at a table regularly with family that you like, it sort of prevents everything. That's a joke, but it's very good for you.
Yeah, Lena, there's so many things.
There's time for one more question if there's an area we haven't touched you'd like to raise.
Sure. I think this one would be a good one to finish on. Someone wishes to know if there are any clinical trials underway that may potentially offer alternatives to dialysis and kidney transplant in the future.
Oh, wow. Associate Professor Ivor Katz, please.
Okay, so this is an extremely exciting area, but I'm going to touch on 2 things instead of the one. I'm going to address this issue of these new exciting treatments, but I think one of the things are asked in the questions are people aware of the new drugs and medications that are out there? And I think we should cover it here because that also fits into this group. So traditionally, we've had this group called RAS blockades, ACE inhibitors. There are actually really new trials that have been amazingly successful in supporting it. And you'll probably just pick up any newspaper and you'll find them. They're called gliaflozins or SGL2 inhibitors. And the drugs are called dapagliflozin and empagliflozin. Those drugs came out in very big trials in 2023. They were so successful they were originally diabetes-related medications, but they had such success in reducing all the cardiovascular events, strokes, heart disease, hospitalization, and they significantly reduced people getting kidney failure. In fact, the trials were so successful, they stopped them very early on because people would. So that's now available to us and available in Australia for people with kidney disease. There were the new drug. There's a new drug called finerenone, which we use for type 2 diabetes, very similar. And of course, the one that everyone loves to talk about is Ozempic or GLP-1 agonists, which help you lose weight. And these GLP-1 agonists are really a key. And there's been a number of studies that Australians have been involved in. Vlado Perkovic, Prof. Perkovic from UNSW, in the FLOW study that was published in the New England Journal just last year, showed that Ozempic or semaglutide really made a big difference in reducing kidney progression. Of course, that's losing weight, so some people just can't do it necessarily, or there's different reasons, and there's good clinical reasons to do that. So those drugs are revolutionizing your pathway and how quickly you'll get to dialysis, or your kidney function will decline. And really, it's our aim as kidney specialists to try, if we can, never get you on dialysis. So we'll all die with our kidneys never working 100%. That is the truth for everybody as you get older. So what about the new treatments? Well, I think the big one everyone is seeing really is the pig genetic changes that are happening. So I think towards the end of last year, there were a few cases where genetically modified pigs, we have this very new tool. Well, it's not so new, it's been for around. We have got this CRISPR-Cas9, which is a special protein that we can clip and genes, and we can now create pigs that can match our genetic profile. Obviously, it's very expensive at this stage, and unfortunately will probably not be available to anyone but the rich countries. But certainly that is in a very exciting area, and if that works well, there's the potential to do that. There are a few machines that they're looking that can be implantable. They haven't been as successful, but it looks like the xenotransplantation, so transplanting from animals to humans, seems to be working. And there's a major trial starting to happen, which will be 50 patients at Harvard. The man who started it is a guy, Ruella, who did the first on people who volunteered, who had very advanced renal failure and had complications and were prepared to volunteer. But now it's actually being offered, and that could potentially make a big difference. But that's probably still a few years away.
Just to be clear, what are they offering in that last clinical trial you were talking about?
So they're basically now, these are people who would be on a wait list. So everyone who's on dialysis will be on a wait list in Australia, and that wait list will be on average about 4 or 5 years, unless you have a related donor or somebody who will be giving you a kidney. And so there's a lot of people on these wait lists around the world, and in America there's people on the wait list who are putting their hand up to participate in these xenotransplant trials. But so I think those
an animal coming into you, is that what you mean?
Basically, it's the kidney of the pig that's been genetically modified to match your body.
Yeah. God, that is absolutely amazing, isn't it?
Yeah, so that is exciting, but I don't want us to get carried away. Probably still the best things to do are to do what we spoke about this evening, diet, lifestyle, and all these new medications that we have available to us.
I promise you, Ivor, I'm not heading towards a desire for the pig. I'm going to be exercising. I pray that I'll lose weight, and I'm certainly going to improve eating. I'm going to just live with my general practitioner so that I can have constant communication. And I am going to ask about that blood test to find out about my kidney function.
And I suppose it will be a Jewish question whether we can have the pigs, of course.
Listen,
one of the rabbis will have to.
I know that is an ethical question. Exactly. I don't mean to be.
There's lots of ethical questions. Yeah.
There is a big ethical question there. Could you give me 1 minute, Kelly, on gefilte fish? Are there any dietary issues, particularly around Jewish food? None at all.
Oh, no. So all fish is good. And if you choose to eat a particular type of fish, make sure it's the right portion size. That's the simplest advice I can give.
It's not the fish, it's the sugar in the fish. That's the problem. The sugar that you add to the fish.
Well, that is a problem. But, food is pleasurable. You've got to enjoy it too.
And
tell me the carrot.
Can I just going back to the ethical issues regarding the trial, a small trial in relation to part of a pig saving your life. There are a part of Jewish thinking is that saving life is critical. But I'm sure if we had a number of rabbis, we'd have a fabulous discussion. But look, I just want to really thank Associate Professor Ivor Katz Associate Professor Kelly Lambert and Professor Itamar Levinger for a really dynamic discussion about chronic kidney disease and how we can manage our kidneys to work well for our lifetime. And thank you so much to Dr. Lena Safro, for her lively questions, and to you, the audience, for watching. We will be sending you a feedback survey as viewers. Please complete it and send it back, because the Wolper Jewish Hospital team really do read them and take them into consideration. A reminder, we have recorded this webinar and it will be available on the Wolper Jewish Hospital website. And if you go there, there are a whole range of webinars recorded on many topics. Our next webinar is the 7th of May. The 7th of May, and the topic is Ready, Set, Recover, Steps to Smoother Surgery, the surgery journey. So it's all about what we can do to promote good recovery and good management from a health perspective of our surgery. My name is Julie McCrossin, and it's been an absolute pleasure to be with you. Good night and goodbye.